Megamind.
Hello everybody, this is Fabrizo Colombo from Milan, Italy, and today I'm very happy to be here and have this great opportunity. So the first things I would like to do is to thank Megagen Italia, Megagen, Dr. Park, and MINEC to give me this great opportunity. So we have just 15 minutes, so I would like to go straight to the point, and I would like to introduce my clinical case. The title of my presentation is Vertical Ridge Augmentation of Atrophic Anterior Mandible. And the first things I would like to do is to share with you the face of the patient that I decided to treat. She's a very nice girl, Italian girl. She is a 56 years old patient. She has no systemic disease, no periodontal disease. She has a good dental hygiene. She is the typical ideal patient that we would like to have in our dental office. And observing the intraoral point of view, the initial clinical situation, what we can see is that everything is in order. Everything seems to be fine, but the patient came to my dental office complaining a problem, complaining bleeding in the lower part where we can find this little mini Toronto bridge. And she told me that every time she was trying to wash this part of the mouth, she was also painful. So the first consideration that I would like to share with you is that evaluating the initial clinical situation from an prosthetical point of view, we can see that we would like to reach a longer teeth compared with the one that we already have in the patient, in the mouth of the patient. And once remove the little Toronto, we can see that was not an implant-supported rehabilitation, but there is also a tooth, and we have the lack in a vertical dimension of hard maybe, and hard and soft tissue. So observing the initial clinical situation from an X-ray point of view, what we can see is that we have a loss of bone around the implants, and we also have, as I told you before, a tooth that I consider a hopeless tooth. So observing everything in a more precise way, we can see that we have an extreme loss of bone, and my decision was to remove everything, remove the implants and also remove the tooth. But after 4 months of healing, what we get is this kind of clinical situation, so a vertical atrophy. And also observing from a lateral point of view, we can see that we have maybe 1 centimeter of a vertical atrophy that we need to go to manage. And the first things that I would like to suggest you to do is have a talk with the patient and understand which is our goal, which is the goal of the patient. And the first thing that the patient told me was that she didn't want to once again have a Toronto bridge in her mouth. So the other solution that I proposed to the patient was to rehabilitate everything, facing a regenerative surgery, a regenerative treatment plan. But the most important question that I would like to share today with you is which is the prognosis of this defect? We have to respect a lot of rules in this case, but the first one that we need to know is that the chance, the opportunity that we have to regenerate the bone is the one that I will show you. And we have to consider that the boss in this case are the papilla, the tip of the papilla, and we will be able just to regenerate the bone under the line that pass between the right papilla and the left papilla. But in this case, evaluating the initial clinical situation, we can understand that we have a problem because we have a loss of soft tissue, and the CEJ line of the adjacent tooth was not covered by soft tissues. And obviously the patient would like to arrive to reach this kind of ideal clinical situation, but to reach it, we need to remove also the canine and to start to regenerate from the papilla, the major papilla of the premolar, the first premolar. But I don't want to do this kind of thing, so I decided to tell the patient and tell her that The only way and the only reachable line that we will be able to reach is the green one. So at the end, we will have longer teeth. Today we are lucky because we can work using this kind of software, and you can see that we are able to study the DICOM files. We can add also STL, and we can plan everything in advance. And we can see that we are planning a prosthesis composed by 5 incisors. And if you look at the right part of the screen, we can see that placing the implant is this kind of initial clinical condition. We will have an exposure of the fixture, and this is the reason why I decided to go to regenerate the bone. And if you want to understand more about the clinical situation, now we are able also to measure everything, and what we can see is that in the central implant we need to regenerate at least 9 millimeters, and in the right one at least 1 centimeter. So the treatment plan is to first regenerate, so perform a GBR surgery, obviously using something spacemaker, and I decided to do it using a PTFE membrane, obviously a reinforced one. Then we need to go to wait for 8 months, and after 8 months we need to go to reopen everything, to remove the membrane and to place 3 implants, and after other 3 or 4 months we need to go to manage the soft tissues, and then we can start managing the prostate. So this is the first surgery, and obviously we need to open a full thickness flap, because one of the first rules that we have to respect in this case and is to maintain and to keep in contact the graft with the receiving side. Then the first things I would like to do in the first part of the surgery, when I'm not tired, is to perform the periosteal release that, in my opinion, is one of the most important part of the surgery as a key of success. And in this case, I love to show this video because you can do it easily, removing just the periosteum using an automatic instrument and performing a pulling up, but in this case I had some scar tissue, so I decided to use the tip of my blade and to interrupt the periosteum, and after done it, to go to release the flap using an automatic instrument, and you can see that we can reach in this case, and using this procedure, more than 12-15 millimeters of a release of the flap. And now we have to go to perform decortication holes, to place some screws, spacers screws, just to stabilize better the reinforced PTFE membrane. And now we have to go on placing the membrane, stabilizing everything on the lingual side, and once done it, we need to harvest autologous bone and to mix it with the heterologous one. And I love to do it, in this case, using 70% of autologous bone, 30% of heterologous one. And you can see in this video how you can get, how the biomaterial is plastic thanks to the presence of the high quantity of autologous bone. And once done it, we need to go on and to overturn on the buccal side the membrane and to stabilize everything. And this is a picture of the primary closure on the wound, just a few minutes to dismiss the patient, and after 15 days we are more than happy to see that everything was fine, there is no suffering, there is no infection, and we can go on removing the suture. And now we have just to wait, and after 8 months we can see the clinical situation of the patient. Everything was fine, and we don't have to forget the journey that the patient needed to face during the healing time. And looking at the right part of the screen, we can see that we are on the right way. And now we have to evaluate everything from the X-ray point of view, and we are once again more than happy to see that we have a great amount of bone, where to place our implant, and we are planning everything in advance, and I would like to share with you and to show you also the video of the reopening. Obviously, also in this case, we have to perform a full thickness flap. We have to reach the surface of the PTFE, and once done it, we need to remove the screws that we have used in the first surgery to stabilize everything. And we can see that under the membrane we have a great amount of regenerated bone. And I'm not scared about the clinical situation that I'm finding in this picture, because you know, in the crestal part we have yellow biomaterials, yellow regenerated bone. Obviously, the regenerated bone after 8 months is not mature. And I'm more than happy to see what I'm showing you in this picture. And you have also to consider that after a few minutes, you will go to place the periosteum on the crestal part of the regenerated bone. And at this moment, we will start again a revascularization from the periosteal part. So it's very nice to compare the initial clinical situation with the post-GBR1, and it is very easy now with a great amount of bone to go to place the implant, and you can see that first we have to remove the spacing screws, and using a surgical guide we need to respect strictly the protocol and to go to drill the bone and to place the implant. I would like to suggest you to not to under-prepare the bone, to follow the protocol, because we are managing with a really not mature bone, and if you go to under-prepare the bone, you are running a great risk, because you are stressing the newly formed bone, and you can break the bone, and you don't have also to forget that we would like to go deep with the implant just to compensate the reabsorption that we will have in the following 2 or 3 years, and preparing very well the bone, you can get it. You don't have to forget also that we will go to place the tip of the implant directly in the hardest bone that we have in our body. So this is the clinical situation before to close the wound, and you can see how I love to place the implant under the crestal bone, at least 2 or 3 millimeters, as shown before by the colleagues. And obviously we need to close everything, once again, by primary intention, respect the biological timing, and I suggest you also to be sure to remove everything and don't leave in the wound the PTFE, because you are managing with something contaminated, and you need to be sure to not have infection after the surgery. So about the soft tissue, after 3 or 4 months of implant healing, we are sure about the osseointegration. We are to check everything using X-ray exam, but the most important things that I would like to share with you is that today we don't have to look just at the bone, but we have also to consider the soft tissues. And what I can see in this picture is that the soft tissue are not enough to protect in the long term my implant. And today also the literature give us a lot of information about what we would like to have around the implant. And this very nice article written by Ling and Wan in 2014 taught us that if you have an inadequate keratinized soft tissue around the implant, we could have plaque accumulation, tissue inflammation, recession, and loss of attachment. And this is the reason why I decided to perform a free gingival graft just to increase and improve the keratinized soft tissue around my implant. And this is the procedure that I decided to perform during the surgery. First, we need to open a full thickness, half thickness flap, just to create a bleeding surface where to place my free gingival graft that I will go later to harvest from the palate. And then, once done it, we need to open 3 little full thickness flap on the top, on the implant, just to reach the cover screw, to unscrew it, and to replace it using some healing abutments. And once done it, the following step is to stabilize the alveolar mucosa in the fornix. So at the end, you are rebuilding a new fornix, the one that you moved during the first surgery, just to obtain, to have, during the GBR session, to have a primary closure on the wound. And then we are going, obviously, in 2 parts, in a bilateral part, to harvest the soft tissue, the keratinized soft tissue, epithelial connective tissue graft, because taking it just from one part of the plate is not enough. because you have to cover a very large surface. And once done it, you have to go to stabilize everything. And this is what I got. I usually use a single detached suture on the corner of the free gingival graft and a compressive suture very close to the abutment, very close to the implant. And I'm more than happy to see this final result, but look, the final result after 2 months of maturation of the soft tissue. I'm happy not just because I have a keratinized soft tissue around the implant in the lingual part and the buccal part, but also because I have finally a thick gingival phenotype. And in my opinion, it's very important to preserve, to maintain the volume during the long term. And at this point, we can start managing the prostho, and I like to do it using a temporary screed return, an acrylic bridge, and to compare everything with the initial clinical situation. And after 6 months of soft tissue management and soft tissue maturation, we can see that everything is fine, and it's time also to see, using X-ray exam, if everything is okay. And in this image, we can see that everything is fine. We can go on with the prostho session, and this is the final result. I decided to deliver this screw-retained metal ceramic bridge, and this is the final result. I'm very happy, the patient too, because we reach our final goal. We have the right color and shape, the good mimetism, and we also have what we want to have around the implant. So a great band of keratinized soft tissue. I would like to remind you that the patient needed to be really motivated to face this kind of rehabilitation, because I think that I perform this clinical case in at least 2 years. And the most important thing is that comparing the initial with the final X-ray exam, we can see that everything is fine. And after 2 years of follow-up from the prosthetic loading, we can see that we have a sort of corticalization, crested corticalization of the regenerated bone. And with this last slide, I would like to say thank you, everybody, for being here today and for giving me this great opportunity. And thank you very much, Megagen.
Megamind.